Welcome to this live webinar on learning from COVID-19 frontiers. The event today is only organized by APAC Laboratories with more than 150 healthcare professionals dialing in from Asia Pacific region. During the webinar, if you have any question, please click on the Q&A button to submit your question. To officially start the program, we would like to invite the chairman, Dr. Muhammad Munawar from Indonesia, who is one of the founding fathers of Asia Pacific Heart Rhythm Society. He's also the head of working group of arrhythmia and the advisory board member of Asia Pacific Society of Interventional Cardiology. Dr. Munawar, we welcome you to deliver a welcome note.
Oh, thank you, Adrian. I'm very happy to be chairing of this very important webinar. And today we have an agenda of what we call is, the topic is ATS in catheterization laboratory readiness. And I hope that all audience can give us a question to our distinguished guest, Professor Zang Yi. And today we have what we want to learn is update of the COVID-19 knowledge, advance, and impact of our clinical practice, especially for interventional cardiologists. And then provide the latest disease management insight, the split cardiovascular system related to COVID-19. As you know, that China is the leading of the how to manage the COVID-19. And our guest lecturer is distinguished Professor Zang Yi from China, from Shanghai. He is associate senior doctor, associate professor, and intervention cardiologist, Shanghai Dance People Hospital, Tutor for graduate in Tongji University School of Medicine, and invited reviewer and published more than 7 peer-reviewed articles and chapter. So, Professor Zang Yi, please, for your lecture.
Thank you very much. Thank you, Professor Munawar, and thank you all the colleagues and the friends. I'm Dr. Yi Zhang from Shanghai Dance People's Hospital, and today I'm so honored to have this chance to share you some experience in China, in Shanghai, about our cardiologist work during this pandemic. So that starts the first thing that I would like to say. What we are facing now actually is truly a pandemic. You know, on March the 13th, 2020, WHO Director General said, we have therefore made the assessment that the COVID-19 can be characterized as a pandemic. And now we get the number till May the 18th, 19, and have now been reported from over 150 countries or territories with over 317,000 deaths occurred. So what we are facing now is truly a pandemic and a historical moment. And for all the cardiologists that we need to share our experience to better do our work and to united and to support and treat our patients. That's exactly what we need to do. So today I would like to, within this 30 minutes, share several points. Okay. The four items I would like to share. The first is the clinical work in this outbreak, the pandemic COVID-19 outbreak. focusing on protection for the medical stars. It is extremely important. Secondly, we will talk about how to treat for AMI patients, acute myocardial infarction patients, because in this circumstance that a lot of routine procedures need to be adapted to treat for this pandemic, because there are many different situations that we need to rethink about. And the third point that I will talk a little about the treatment for hypertensives during this pandemic. I think you all know that there are some, not rumor, but there are some afraid of the ACER and the ARB use in the pandemic, not only for the COVID-19 patients, but also for the healthy patient, but with hypertension or heart failure or the diabetes. They are treated routinely with the ACER or ARB. They are afraid with the use of these tablets will increase their susceptibility and or the severity case to become severe case of COVID-19. With this fears that they refuse to use it. Even some doctors at the very beginning, some societies recommended that to discontinue use of these agents. It is harmful actually. And lastly, we will talk about the future. The COVID-19 will soon later that will end, and how we can do better. Especially, I will focus on the telemedicine, maybe only on how to manage blood pressure management during the pandemic with the use of telemonitoring and telemedicine. We are actually initiating some clinical trial focusing on this part, and I hope that all the colleagues that can give us comments and your thinking about this this future of the application of this new technology in the chronic cardiovascular disease management. Okay, so today we will, I would like to further start with the clinical work in this outbreak. So we know that there are some study indicated that the pandemic of the coronavirus started from the October the 6th to the December the 11th in human. That is from the animal to the human. Not only in Wuhan, but in some spots worldwide that there are some gene study, especially this G-SAID study indicated that. So actually, before we know this, like for me, it's like at the end of the January, I think actually there has already in the world that there are some new or some emergent human infections occurred like 3 months ago. Okay, so it is a very beginning. And then if there are some publication in JAMA, there is a comparison between the Chinese solution or Chinese reaction to this pandemic. The left side is the SARS, the outbreak occurred in 2002 to 2003, also in a summer, in a winter. And for the COVID-19, the outbreak occurs like, what do we say, it's from the January and at the end of the January. So if you take a look at this time flow, that you will notice that for the, because that we, as Chinese, we experienced the SARS before, and we really learned a lot or get a lot of lessons from the SARS outbreak during that time in 2003. And now, when we are facing the COVID-19 outbreak at the very beginning, that there are some regulations, restricted regulations that we totally locked down Wuhan, the city, and there are millions of people there, but we locked the city in order to prevent the spread of this coronavirus. And then all the regulations and countermeasures take place more quickly as compared to SARS in the SARS outbreak. And you will notice that there are very quick reactions for this outbreak. And finally, it turns out that all of this countermeasures is very effective. And if you take a look at the first 1,700 COVID-19 patients, it's totally the 44,000 infectors. The healthcare personnel take about 3.8%. So that is to say, at the very beginning, there are over 1,700 doctors or nurses actually infected by coronavirus-19, and with 63% in Wuhan. And if you take a look at close to 15% cases classified as the severe or even critical cases, and 5 deaths occurred at that time. So you will see that at the very beginning, we treated the COVID-19 sort of like we treated SARS at the end of the SARS outbreak, because we think that it is coronavirus, it's not that sensitive, or the susceptibility is not that high. But then we realized that it is not SARS, because it is that the combination of the coronavirus through the S protein collecting with the ACE2 protein is like 10 times or 13 times closer than the SARS. So that is to say, humans are more sensitive or more susceptible to the COVID-19 than SARS. So that is why at the very beginning, we have limited knowledge about it. There are a lot of doctors and nurses come to the frontier and to get infected during their treatment on the patients. And but later on, if you take a look at this, from the January the 21st to the January 31st in Wuhan or in whole China, the infected doctors and nurses are very high. But later on, after February the 1st till at the end of the March, 2 months, there's only 173 nurses and doctors infected in Wuhan. So why that when go on with treatments that we be more clear, we get more clear about the situation about this coronavirus, because at the end of the January, from the January the 21st to the March the 3rd, there are 7 editions or versions of the diagnosis and treatment of COVID-19 guideline has been released by Chinese government, the CDC, because about sometimes even 1 day later, they change another version because we get more message by knowledge about this disease, and we spread it to the nation. Every health providers get knowledge about how to treat the COVID-19 patients and what is the most effective way to protect yourself. So there are a lot of documents being released during that 10 days, 40 days. So it is a very effective, very important knowledge for us. And then if you take a look that from the January the 30th till the February the 21st, there are a lot of the documents or the consensus on how to treat AMI patients or STEMI patients, or how to use the to treat the severe cases, or to use the ECMO, there are a lot of consensus to teach cardiologists how to work in the front line to treat their patients. It is very useful, this all of the documents and informations. So if we sum all of these things, how to protect ourselves and how to treat the patients in front line, that we get the general principles, that is to suggest the house quarantine, avoid unnecessary hospitalization, to persuade the patients with not a severe case or acute case, just to stay at home. If you get hypertension, that you can get the remote consultants or to get the tablets, and just to stay at home. Do not come to the hospital at the very severe period or very dangerous period, like in the February or in the March. And then for the confirmed patients, we isolated in situ. We isolated in situ in the hospital, at home, or in the ward. And there are a lot of blocks that can help us to isolate the patients and to avoid the coronavirus spread. And for the suspected patients, we need to treat it in the designated hospital and designated operation room and also the ward. In Shanghai, for instance, all the confirmed cases and need to be transferred to a hospital designated for the COVID-19 patients about 50 kilometers away from Shanghai. And there is a catheter lab that can do the treatment for the patients. And for the patients with fever that need to go to the fever clinic, I think in China, the fever clinic is very, very useful because by the body temperature check that you can get the suspected cases. And so the body temperature check is be placed in the entrance of hospital, in the entrance of the supermarket, in the entrance of school, and entrance of factory, the supermarket, and every place that you go to different entrance that you get your body temperature check. If you get fever, you are persuaded to go to the fever clinic to get treatment. I think it is a very useful, effective strategy to test the patients. And then if for the fever patients, that we will do further the test, the coronavirus test and the antibody test, and go on. So lastly, the intervention, all the interventions can be done without the relatives or families' signature, because before this outbreak, that the relatives normally need to sign their names in order to like the consent signature, to then the doctors and the medical team can do operations on the patient. But now that you get a phone call or you get a contact, and then the doctors can make the decision to treat or even do the operations on the patients. That's to avoid unnecessary contact between the relatives and doctors. So this is one of the principles. And here is some personal protection equipment and like the integrated protection clothes. It is very useful. At the very beginning in China, that we're short of this PPE, and later on all the factories and the government that to suggest the different factories to give sufficient supply of the PPE to the big cities, to the COVID-19 hospitals, and also the hospitals with a fever clinic. And also the gauzers and the infrathermals and N95 masks and all this stuff is very useful. And we need a large amount of this PPE in order to continue to work, because protect the medical team is essential for this during this period. And the fever clinic, actually, I has already mentioned that the fever clinic is the most effective strategies that we can do. And because with the body temperature check, you can see in the picture, the body temperature need to be checked for every patient, for every patient's relatives, for doctors and nurse, and even the passengers that you need to check the body temperature. It is very useful because we get this knowledge from the SARS outbreak during 2003. And then for the patient transfer, that all the things is a designation, because we need the designate staff to help the relatives and to help the patient to be transferred to the designated elevator and the designated cath lab. Because during that time, we still need to treat patients with acute myocardial infarction. So this pathway is very important, because all of this pathway has been be only for COVID-19 confirmed or suspected patients, COVID-19 patients. The first is about the clinical work in the outbreak, how to protect the cardiologist and our medical team. And secondly, I would like to talk a little about the treatment for AMI patients. There are some also general principles, because we need to initiate the nearby treatment to the patients of AMI to seek and receive medical treatment as the nearest medical institutions, and to minimizing the patient's transfer. And then the safety protections. It's not only for the patient, but also for the doctors, that there are 3 levels of the protections, but the doctors and the operators in the catheter lab and also in the CCU need the top level of protection for the patients. And priority of thrombolysis, or we can say, because in China that we have some flow chart that to suggest that, because when you do the PCI, primary PCI in the STEMI patients, that you need a whole team and you need a designated catheter lab. But the catheter lab is not qualified for treat the COVID-19 patients. So in this case, the fibrinolysis treatment is priority, has the priority, because they can do it in isolated room. Only one nurse and one doctor can give this kind of treatment. The patients will be tightly monitored. But if the patients need the primary PCI, if it's confirmed the case that we need to transfer these patients to the catheter lab about 50 kilometers away from Shanghai. So that is for designated transport. That is very important, because all the systems that need to be predetermined or pre-planned in order to avoid the other contact and infection. And remote consultation, not only for the patient with chronic disease at home, but also with the patient in the fever clinic or even in the ward, that because the doctors can talk about this case with relatives and share some images, and all these PACS system need to be ready for the remote consultations, because all the information need to be transferred very quickly, and so doctors can watching these videos and images, and then to discuss about the further treatment plan for this case. So remote consultation is also very important for the treatment of AMI in this case. And this is the flow chart of the diagnosis and treatment for STEMI patients. We need to balance the risk and the benefit. And if the patients will get the STEMI, and at the same time that it is a confirmed case, that, as I say, the priority of the fibrinolysis treatment. And if the patients that really need without the stable hemodynamic condition, that the patients need to be transferred directly to the catheter lab, designated catheter lab in the rural areas to perform the primary PCI on this case. So summary that there are 5 general principles in the treatment of AMI I have already shared. And for the STEMI patients, different treatment strategies should be selected based on three things. The first is the possibility of the COVID infection. It is a confirmed case need to be transferred immediately. The time window of the STEMI onset, it is within 20 hours. We need to take account of the transfer time delay and also the vital signs are stable or not. It is also very important. For non-STEMI patients, treatment strategies need to be selected according to 2 things. The first is the possibility of the COVID-19 infection, and then risk stratification, like the grade score. And we need to strictly assess the contradictions and the indictions of the fibrinolysis. And self-protection is also always of great importance, because we know that at the very beginning in Wuhan, there is a COVID-19 positive case with acute myocardial infarction. The whole team, including the interventional cardiologist, the residents, and all the nurses, the whole team get infected by this single case with confirmed COVID-19 and acute myocardial infarction. So then I will talk a little about treatment of hypertension, the use of ACER and ARB. We all know that at the very beginning, we get the knowledge that first things, the coronavirus through the S protein were combined by the ACE2 and to get into the pulmonary tissue. That is the gate or entrance of this coronavirus. Secondly, we get the knowledge that the use of ACER and ARB in animal model and in clinical data all show that the use of these tablets will increase the expression, will increase the ACE2 level and also the activity. So people and doctors and patients suspected that with the use of the agents will increase the entrance protein of the virus, will increase the susceptibility and also the severity of COVID-19. So that is all what it is started. And then we all know that there are some guidelines and some society, International Society of Hypertension, European Society of Cardiology, AHA, ACC, all released some document to say that till now we do not have sufficient evidence to let our patients discontinue the use of ACER and ARB, and they believe that it is harmful. Actually, later on, there are many retrospective observational studies focused on this issue, all get very similar result to say that it is not good for you to stop the use of ACER and ARB with the consideration of the COVID-19 infection or even the severity of it. For me, my personal experience, I get our information about the stopping use of the ACER and ARB on the February the 7th. At that time, I wrote information or educational notes or articles in Chinese and spread it to the social media. And a lot of doctors and patients should get the knowledge based on current evidence, even animal evidence, that you are not wise to stop use of these agents. And then I share this experience or this information with Chinese colleagues, with European colleagues, and also we have a collection, webinar as today with the ACC and AHA colleagues that we share some experience about it. And it is very interesting because a lot of doctors have this doubt, but with the evidence to show, and then you realize that we need to continue the use of it. And they face the same situation as I did. There are a lot of patients ask that if we need to stop ACER and ARB. And during that time, I worked with Brian Williams, and you may know him. He is very influential hypertension expert. He is a corresponding author of the European Society of Hypertension Guideline in 2018. And I collaborated with him for a long time. And during my sharing with the information, I was invited by him to co-author one article on Lancet about the situation, like we do not need to stop ACER and ARB treatment. And we also have other collaborations, and I will show you later. And also talk about the future and after the COVID, and if we same situation, how can we do better? How can we do better to treat the chronic heart disease like hypertension or diabetes or something like this? I think telemonitoring and telemedicine are very useful. So for this, that there are some hypertension management during COVID-19, and there are, excuse me, there are some strategies, but I do not want to go further with it. In the literature, there are many good publications, especially the Tasmin study conducted in England to show that it works quite well for the telemonitoring and telemedicine for the blood pressure management. And what we do is we're about to initiate a clinical trial, randomized clinical trial named Singapore study. And with the combination of the blood pressure monitoring and upload it immediately to the website, and also the predetermined traffic light protocol to teach you how to titration of your antihypertensive tablets, and then you may get your telephone medicine by your GP every 2 weeks in order with this system to better treat the blood pressure at home. That means the hypertensives can stay at home and to get all of this treatment, to get the tablets, to get their blood pressure monitoring, and it may help the management of this. This is a study design. I do not want to go to the detail about it. So that's the end of my talking, and I'm so glad to have this opportunity to share you with some knowledges and experience and some lessons we have during this pandemic, and also the ACER ARB use, and also in the future, if we can really take good advantage of the new technologies like the blood pressure monitoring, the device, and also the platform can do the telemedicine and better titration of the blood pressure tablets, that in the future, when we will face some situation like this, we can treat better with our patients. That's exactly what I want to say. Thank you. Thank you very much. Thank you.
Okay. Thank you very much, Professor Zhang, for a very excellent lecture regarding your experience in China, from management of army or STEMI until what's real world in treating with its inhibitor and ARB, and then for future management with telemedicine. And I do believe that there's many of question, Professor Zhang, especially if we look at your data in China that, you know, the COVID-19 is actually very fast to be controlled because of so many things. And one amazing thing is that your data among about 3.8% of the health personnel is affected, but only 5 deaths. So what's the question is that for protecting of the health personnel is that how often should the doctors or nurses to be tested for COVID-19, because it's very important for them. And then what's the recommended of PPE for frontline staff? That's the simple question is. I do hope that you can answer the simple question from. We start from that, please.
Okay. Okay, thank you, Professor Munawar, about the questions. Actually, in China, yes, I think as I mentioned that we are lucky and we are also unlucky to experience SARS in 2003 because it is another coronavirus. So we actually accumulate some experience about how to deal with this coronavirus. So in this case, that in Wuhan, at the very beginning, as I mentioned, within 10 days, I think over 70% of the the infections during the health providers occurs within the 10 days, the first 10 days. But after that, the infection rate is much lower. And you mentioned that only 5% of the only 5 deaths during this period. That's because we have a lot of information and all the medical sources have been focusing on this medical SARS with COVID-19 because the country believe that they are heroes. They are heroes and they sacrifice themselves to the nation. And so a lot of like the ECMO and a lot of very useful and effective medical resources had been put that, and I think the mortality rates during this health providers are relatively low. And as you mentioned that how often that for the medical stars need to be treated, to be tested, for us that we still believe the fever is very important. The body temperature need to be checked every day. You know, for instance, that now I'm working in a hospital in Shanghai, that every day that I need to report my body temperature to the platform, and also that I needed to get my body temperature checked when I entering the hospital. Even I entering the ward that I need to get my body temperature checked. But for the as you mentioned, the COVID-19, the antibody or the test, swab test that not routinely performed actually in Shanghai, and we are suggested that to get this test, if you get fever and you get any symptom like this, and or you contact with the suspected case or confirmed cases with the quarantine at the same time that your COVID-19 swab or the antibody was tested. And then for the PPE, I think as many as possible for the medical SARS, I think, because there are a lot of work actually, and even there are some place, there are only a few patients in some town but you need to open your favorite clinic, and if you do this, you need a large amount of the PPE to protect your health providers. So I think as many as possible for the PPE. Thank you.
Okay, thank you very much regarding and because is any your recommendation of the test? Which company? I don't talk about the company, but I mean, is any specific test that to be done? Because right now, Abbott, the information that launches of the new test for rapid test for the COVID-19. That's number one. Number two is that what are your patient triage strategy for COVID-19 containment measures?
Okay, so the first question is about the test. I think for the test, the quicker the better. I think you need to get a result as soon as possible, because to avoid the COVID-19 spread or to unnecessary contact with healthy people. So I know that in China that we have some tests you can get results like in hours. I think it's not quick enough for us. And I know that in Korea, in US, that especially in Korea, there are some tests that they can do get results within 1 hour. And I know that I get the information in Abbott's that there are new some tests can get results with minutes. I think if you can get the results within minutes, I think it is going to be ideal for the treatment, because you can get the treat very quickly to get your answer, and then you can go on with your work and go on with your treatment. I think it is very important. It depends on the sensitivity, the specificity, that of course for any test, but the time from you get the test till you get results is very, very important in this situation, especially in some dangerous places. Yeah, thank you.
Okay. Okay, Dr. Zhang. And as you know that in COVID-19, is the comorbid is very important. I mean, it's not only this atherosclerotic heart disease, but also very so many things that like valvular heart disease, non-CAD arrhythmia, cardiomyopathy. According to your experience, which has a high case fatality rate? That's number one. Number two is that regarding those patients has COVID, but has also has comorbid or valvular heart disease, such rheumatic heart disease, what's your experience or your recommendation regarding management, especially for giving anticoagulant? Which agent you prefer?
Okay, thank you for your question. Yes, it is a very important question, because we know that all the data suggests that if the patient if the patient is aged, like over 70 years old or 65 years old, if the patients get more comorbidities, and they are more likely to become the severe case. And in our analysis, it shows that the highest one is actually is hypertension, because some data show over 60% or 70% of COVID-19 infections are actually hypertensives. But we personally, we have our own analysis on this data. If we adjust the age, that's a lot of the comorbidity, the association between the comorbidity and the fatality of the COVID-19 disappeared. Even the susceptibility of the with the comorbidity. But for me, I think the diabetes is very, very important because a lot of data suggested that the patients with diabetes and with COVID-19 are more likely have a very high fatality or mortality in these cases. I think it is because with diabetes that it is not only your heart problem, but all your tissues has been influenced by the high plasma glucose situation, and all the immune system has been affected by this condition. And with this effect that for all the infections will cause more harmful damage to your body, and it's more likely to have the very severe or critical case. So that is my opinion. And your second question is, yes, I think this is very, very common that we know that the anticoagulation therapy are very how to say, a very useful treatment to the patients. I think theoretically that we know the ACE2 actually expressed more in the endothelial cells, and like in the vessel, that is like the intimer area of this ACE2. So when the virus contacts the ACE2, it will have a huge or a very harmful damage to the endothelial system, and then it will cause a lot of thrombosis, and it's a tiny thrombosis. So so it is very common for us to observe some COVID-19 patients get a very high or dramatically high D-dimer, like 20 or 40, like this. And so anticoagulation therapy in these patients are very, very useful. Actually, for me, inoxaparin is one of the best choice for me because it has more clinical evidence to support its efficacy and safety in cardiovascular patients. So I think I will choose this. Okay.
Yeah. Okay. Thank you. So there are a lot of questions from the audience. Another question is that are there any markers? Are there any marker to predict onset of cardiovascular problem for patients?
You mean the biomarker in the COVID-19 patients?
Yes.
Actually, not exactly. There are some reports. I think not only in COVID-19, but also in SARS in 2003. There are some reports to say in the SARS patients or COVID-19 patients, we will observe some cardiac damage in these patients, represented by the increased chopping. And but if you take a look at the data in Wuhan, published in JAMA Cardiology, they say that I think among like several hundreds COVID-19 patients, about 13%. I read another number is 14%. So that is to say 15%, more or less, COVID-19 patients will have increased the chopping eye. So, but normally only have a slightly increased troponin I. But if you group these patients, they do the analysis like the Cox regression or the likelihood test, the data all show that the patients who have the cardiac damage or the patients who have or even slightly increased troponin I will more likely to combine with the cardiovascular disease and also have how to say with increased fatality or mortality in this case. So that is to say the patients with increased troponin, cardiac troponin I, or the or combined with the cardiac damage, cardiac tissue damage in this case, have a poor prognosis. I think there are also some data from the animal studies. I think in animal studies, the problems or incidence of the cardiac damage during the SARS infected mice are more. I think it is over half of the SARS infected mice had damaged cardiac tissue, and they also observed the virus or can found the virus in the cardiac tissue. I don't know if it is the case for human, for the COVID patients, but at least in the animal studies, there are some reports to say that with the SARS-infected mice, if you do the biopsy, that you will find the virus and the antibodies in the heart of the mice. So I think there are also some evidence to support this theory. Okay, thank you.
Okay, okay, Professor Zhang. It's still another 2.5 minutes, but there is one very interesting question that might be we can hear from you. That the question is that for elective procedures, which screening tool can be done or useful? Is any rapid test or PCR, or might be MSCT, lung MSCT is which important? Or do you use all the three things of this screening test for asymptomatic patient who want to be performed for procedure, angiography or PCR whatsoever?
Yes, it is a very very good question. Actually, in China, it's like because at the very beginning that we focused on the fever, the sign of the fever, the high body temperature is very important because we get the experience from the SARS outbreak, and then now that with more and more reported asymptomatic COVID-19 patients, we started to say only the body temperature check is not sufficient. Now that we recommended the PCI test and also the antibody test, the Swamper PCI test, and also the antibody test, COVID-19 antibody test, they combined these two. But it depends on the time delay. That means from you do the test until you get the results. I think the time is if the time is short, it's like say 15 minutes or something like this, it's going to be very useful. It is it has its priority. But sometimes if it takes days or like 24 hours, it's not so attractive. So in this case, if it is like hours or days, I think, and what we do here is we do the test and also we do the CT chest scan. It is also very useful because there are some characteristic signal or the sign in the CT scan, in the slides that you can show has very highly confirmed cases of the COVID-19. And but if about that in the future that we will have get the PCI results or the antibody results within minutes, I think it's sufficient to rule out all the other patients and for us to diagnose the patients. Okay, thank you for the question. Thank you.
Okay, thank you very much, Professor Zhang. Because his time is up, then I can make some summary that nowadays, COVID-19 is become pandemic, it's global pandemic, and I think it's the number of affected people is more than 6.5 million. And very important, very impressive is that in China, in the first time, it's #1, but still, the number is about 80-something thousands, and the mortality is still very low. And especially very amazing thing is that the number of health personnel death is only 5. That's really very, very important. And we are, Dr. Zhang is talking about the STEMI management during pandemic, that more conservative, of course, rather than procedures, and because we have to do with screening tests very tightly. And regarding the ACE inhibitor and ARB, even though that theoretically may be affected with COVID-19, but robust data is not really appear until today. So stopping of the ACE inhibitor, ARB in those patients in need for that kind of a drug might be not wise. And because of COVID-19 become the new era, the new normal, and telemedicine might become more important for the benefit for the patient. I think that's the summary of the lecture of Dr. Zhang. Back to Adrian and Eben. Thank you.
Thank you.
Adrian?
APAC live webinars on learning from COVID-19
We cannot hear you.
finishes.
Yeah.
Thank you very much. So APAC live webinars on learning from COVID-19 frontiers finishes here. We thank Dr. Munawar and Professor Zhang's contribution, and we thank you all for your participation. We would like to invite you to the upcoming webinars in this series on COVID-19 cardiac complications on the 10th of June at the same time. We would also like to have your support in giving us feedback. Please click on the survey button on your screen to participate.